This is Dr. Apratim Chatterjee. I am the Director of Stroke Medicine at the Institute of Neurosciences Kolkata, and I have with me a special guest, Dr. Sukalyan Purkayastha, who has been the HOD of Neuroendovascular Department of Institute of Neurosciences Kolkata. Hello sir, and welcome to the talk.
Hello Apratim.
So today we are meeting for a special purpose. This is in regard to the day we are celebrating on May 15th worldwide as the World Thrombectomy Day. But before we start, we must tell that this modality is an important treatment for acute stroke, or rather acute ischemic stroke management. So before starting this discussion, a few words about what stroke is and how it can be identified and why it is important to identify. So stroke is a disease of vessel of the brain gets clogged or obstructed, or the blood circulation stops and the part of your brain starts rotting. And it is very important to understand and identify it early because it is a time dependent therapy, and as time goes by, every minute counts and the millions and millions of neurons are permanently destroyed. So how to identify it early? Well, we have a mnemonic called the B FAST, where B stands for balance, E stands for eye, F stands for face, A stands for arm or limb weakness, S stands for speech difficulty, and T, as we said, most important is the time. Now I would like to ask Dr. Sukalyan, so how do you think mechanical thrombectomy has evolved and is an important therapy in acute ischemic stroke management?
Right. So how this mechanical stroke treatment of thrombectomy or thrombosuction, whatever we say, it has evolved over time. So I came to Calcutta and started this mechanical treatment. At that point of time, we did not have any stent or all those fancy stuff available with us. So we used to enter inside the blood vessel and used to dissolve the clot with the injection of TPA or urokinase. So that was the way back in 2006 I'm talking about, when the stents and everything was not available. So now we had seen after that there has been a paradigm shift in the treatment, and that has been helped by the trials which has been published, because at that point of time there are not very good trials in favor of mechanical thrombectomy which got published over time. And nowadays we have a very strong base or the scientific background with which we can perform mechanical thrombectomy. And to help us, very good kind of materials which are available. We have very large bore catheters. We can take those catheters, and they're very soft and easily negotiable catheters which we can take up to the clot and we can suck the clot out. We call it thrombosuction. And also we have a stent, which are dedicated stent which are made for taking the clot out from the blood vessel, and we take them under fluoro guidance in cath lab, and we can pinch the clot, we can we can hold the clot and take it out, and we can see that in real time how these vessels are getting perfused, and we can take the clot out. And this is possible to do and to take the clot out in a very short span of time. There is recanalization, and then we can see the change which is happening on the table itself. So there has been a huge kind of change which has happened in as far as the acute stroke treatment is concerned. And what we also tell that how many patients will have to treat to get 0.5. That means if we treat 2 patients, 1 patient will get benefited. So this is, I think, one of a very large, robust kind of evidence as far as the medical science is concerned.
Thank you. So thank you so much, sir, for elucidating wonderfully on the thrombectomy treatment. And multiple questions do come up to us as to how long can we afford this modality, or how long is too long, or what is the time window for stroke. Now we have seen a huge evolution in the time window of acute stroke treatment, and as Dr. Sukalyan was telling, so initially it has started with IV thrombolysis with a window of 4.5 hours, then moved to intra-arterial to a window of around 6 hours, then we have seen trials coming up to 8 hours, then since the last era of Dawn and Diffuse, we have seen the evolution till 24 hours. And I would like to mention here very clearly that, sir, we actually are not dependent more now on the time, rather we are more dependent on the tissue window, and that is very important to us. So if the tissue is salvageable, if we see that if opening the vessel we can salvage a lot of amount of brain tissue, we really do prefer to give the patient a chance, and opening the vessel is always good. So time window, yes, it is important as soon as possible, but definitely no limit, and 24 hours is the minimum time now for our acute stroke protocol. And sir, I would also like to ask you, since as you were telling in the beginning, the results, the procedure was, you have seen how it has evolved over ages. In the beginning, there must be lot of difficulty because of difficult hardwares. Now, just give some idea to us about how far and how supple the instruments have become, and how easily accessible it is, and how far we can actually proceed inside the brain.
Absolutely. So to tell you that, I have to go back to my journey when we started doing neurointervention way back in 2001. So at that point of time, we have only big catheters and guiding catheters. There are no distal access catheters, and those tubes are very hard. And nowadays we have those devices, the distal access catheters, the micro catheters, which has made our life very simple. So nowadays, once we take a puncture in the groin, to reach the clot, it hardly takes around 10 to 15 minutes. Okay, and you can really go very fast and with utmost precision. It's not that while being fast you are injuring the blood vessels. No, you are maintaining the safety and you are being fast, and that's the goal of the treatment, the endovascular treatment. So I would say it is very fast technique, and nowadays we also take the help of anesthesia, so the patient remains very calm on the table, and we can do it really fast. Well, so I would like to ask Dr. Apratim, because he's also a neurointerventionist, being a stroke neurologist, and he does perform regularly the neurointerventions and the stroke treatment. What are the different types of mechanical thrombectomy? What are the techniques you apply in your day-to-day cases? And also, I would ask you, which is a very pertinent question, that what is the importance of a comprehensive stroke center for the success of this sort of treatment?
Thank you, Dr. Sukalyan. So, coming to the first question about the various types of thrombectomy techniques we follow. So, to simplify it, one technique is a suction technique, or we simplify it as an adapt technique, where we try to suck out the clot by a suction catheter. We can use an aspiration suction machine for this, or sometimes we can also use a syringe dedicated to suctioning the clot. Or there is another technique which is with a stent, which is called a stent retrieval technique, where we trap the clot with the stent and take the clot out with the stent. This is called a stent retrieval technique. Sometimes we prefer a combination of both, called the Salumbra technique, and this has got various modifications, namely the SAVE or its various modifications. So this is in brief the various types of thrombectomy techniques we do follow. And coming to the very important second question, is importance of being a comprehensive stroke center. Well, that is what our hospital does. A comprehensive stroke center is a center where we have a 24/7 acute stroke team available. Acute stroke team does not only include a neurologist or a neurointerventionist. It starts right from the home. So the patient calls the ambulance, right? Pre-hospital stroke care, the stroke facility starts. Right from that time, the clock starts ticking. The entire comprehensive stroke center is alarmed that this patient of acute stroke is coming to you. Patient is having a separate sort of an admission criteria, immediately lands in the emergency with the stroke ambulance and is parked and taken special triaging by our emergency team trained in stroke management. Starts from the emergency, then immediately moves to the radiology, which should be 24/7, both CT and MR facilities, including angiograms, and with a dedicated cath lab, a neuro cath lab, which is dedicated for stroke care, where myself and Dr. Sukalyan's team, both we continuously keep working on these patients so that we can revascularize or attain an immediate opening of the blood vessel to give the brain a good circulation. Followed by this, obviously, the patient is going to the ICU, which should be a dedicated neuro ICU, part of the comprehensive stroke team who is trained to take care of the post-operative or the post-intervention management, including the nursing and all the staffs included in the ICU team. Followed by this, we have an extensive rehab who starts the treatment right when the patient steps in and follows through, including up to the home care. So it is a complete 360-degree care, including all modalities of stroke management in our hospital, which comprises the Comprehensive Stroke Care Center.
Absolutely. Thank you very much.
Thank you. Thank you.